Welcome everyone to this free Vulval Pain Society webinar, number 6. So far we've covered vulval pain in general, the dermatological presentations, physiotherapy and various options with that, pain biology and calming the nervous system, and last week we had yoga and meditation. If there are any that you haven't seen and you'd like access to them, please just email us at
info@vulvalpainsociety.org.uk.
As usual, Kay Thomas is in the background in the chat boxes, so if you have questions to ask, please you can type in there. Of course, when you registered, you were able to ask a question then, and we have received over 80 questions for our expert today, and we'll do our best to answer as many as we can. So let me introduce Dr. Winston de Mello, consultant in anaesthesia and pain medicine at Wythenshawe Hospital, Manchester University NHS Foundation Trust. Welcome, Dr. Winston de Mello.
Thank you.
Thank you so much for joining us. We're really excited about this. Your experience in treating vulval pain, I know, is really extensive, so we're not going to go into a full history of that. Currently, I know you're part of a pain clinic, multidisciplinary team. Tell me, what disciplines are represented within that multidisciplinary team, and what's your current role within it?
My team consists of myself and Fiona, who's a pelvic pain physiotherapist, a rather unique character. So we're the ones that will see the patients for the first time. And we also have specialist nurses that feed into this process and do the follow-ups. Plus we have access to vulval dermatology, to urogynecology, gynecology, coloproctology. So we have got a fairly big team, but because it's so expensive to have a big team, we have to triage the difficult cases into a multidisciplinary team once a month.
Right, okay. And your role within it?
I try and run it, usually guiding the patient's journey through this complex pathway.
Okay, all right. So I know, Winston, you have a short presentation that you'd like to share before we dive into the questions we've received. So I'm just going to share that on screen now.
Okay.
Okay.
So first of all, I'd like to thank the Vulval Pain Society for asking me to join them today. It's an important subject. Vulval pain covers a whole multitude of sins, and I'm sure most of you are well versed in this very important topic. So these are my opinions based on several years of practice. So second slide, please. Now, vulval pain is common, and it also covers everything ranging from Vulvodynia to vulval pain caused by other disease processes. It's common. American figures say up to 15% of women will have suffered vulval pain sometime in their life. And one of the questions was, who makes the diagnosis? I guess a good doctor does, usually at general practice. But failing that, the most common ones are by the gynecologist or the vulval dermatologist. The difficult cases then usually go to a multidisciplinary team because the causes of vulval pain can be multifactorial. And information on the subject has to be carefully sought of. Obviously, the Vulval Pain Society is a good source, but I'm always keen that patients get their information from sites or people that are actually involved in the area. Does it go away? Well, looking at Vulvodynia itself, you have a 1 in 7 chance if you did nothing for the pain to go away completely. That means 6 out of 7 of you, the pain will be a chronic pain condition. So my advice is stop worrying about it going away completely, but try and modify your life to adjust to this chronic condition. 80% was a target by one of the questions raised. I think in chronic pain, 30% improvement is regarded as good. 50% as brilliant. But if you're getting 80% plus, you're doing really well. And I can't think of many patients that I've looked after who've had such good results. So I guess you are one of the lucky ones. Aiming for 100% is really futile because so many things affect the way you perceive and handle pain. And life events, which we'll talk about later, also feed into this. The next problem with vulval pain is I've never had a patient who has only had one problem. And here you can see on this slide a list of some of the commoner comorbidities. That is to say, medical problems that coexist with vulval pain. So if you've got vulval pain, it's more likely you'll have bladder pain, irritable bowel, constipation, endometriosis, fibromyalgia, etc., etc. Next slide. And if you look at this list, it's not comprehensive, but on the left-hand side, you can see things like infections like thrush, skin disorders, contact dermatitis as a result of exposure to soap, etc. And all the endocrine, hormonal changes that occur during the menopause can also affect it. Endometriosis, which is where you have uterine bleeding in areas outside the uterus. IBS is very common. Fibromyalgia, which is just widespread aches and pains, and headaches. On the neurological side, more commonly of that group is the pudendal entrapment, which is one of the causes of vulval pain. And it is fairly easy to diagnose because you cannot sit down because it puts pressure on the pudendal nerve. And then you've got your muscular reasons, and this is where Fiona, my pelvic pain physiotherapist, does really well, is that it's like having a headache of the pelvis. So if you can massage these muscles, desensitize them, the input of pain into the pelvis is reduced. If you have had surgery or obstetric deliveries, had an episiotomy or had radiotherapy, if you've had cancer, you're also likely to develop vulval pain. And clearly the impact on sexual activity is obvious and often quite difficult, because not only is it a mechanical problem, but also a psychosexual problem, which we'll discuss later. Next slide.
I skipped one.
If you have vulvodynia or vulval pain, it's a very difficult journey for the patient, because it may start in one organ, like the vulva, and then gradually spread to the other organs, like the vagina or the rectum, or to the muscles around the pelvis. And the reasons for that is that the nerves supplying the pelvis are in very close proximity to the vulva. And as a result of being in pain, your pelvic floor muscles go into tension. So now you've had another added problem to the original nerve problem. And we've talked about psychosexual issues, but there is also an impact on the person, your partner, family, work, and the list goes on. So from a societal point of view, it is a very costly disease. Next slide. So if I see a patient for the first time, Fiona and I take turns in taking a medical history. We take a history right from the beginning, from the time they are born, because quite often there is a hint of what is going on right from childhood occasionally. We also look at life events where stressful things like being bullied or going to school for the first time, going for your first job, getting engaged, getting married, getting divorced, all these life events impact on your pain. And we try and take a comprehensive history because, as you saw in the previous slide, patients rarely present with vulval pain alone. So we like to look at the whole person and therefore tailor-make the treatment according to the individual's special profile. And also we're interested in the family. If you are brought up in the West, you will have socio-cultural differences if you were born in the East. And so there is a rich contribution about the way you're brought up on how you handle pain and disease. And because the bladder and the bowel are so closely linked to the genital system, we try and look for any evidence to see if there's an impact on these functions. Next slide. The examination by us for the first time is usually targeted because most of you will have been examined by gynecologists, urologists, and the list goes on. So we are looking specifically to try and get a diagnostic label, for example, using the Q-tip cotton wool bud test to look at sensitivities around the vulva. Fiona then does a pelvic floor evaluation to see if the floor is hypertonic, i.e. tight. And you remember early on I said Fiona was very special because she's a pelvic pain physiotherapist, which is very different from a women's health physiotherapist. The latter deal with a rather weak floor, and the impact is to try and tighten it up. But in pain conditions, we're trying to relax the floor. So a lot of her contribution goes into getting patients to recognize the tightness of their floor and giving them strategies in which to reduce it. I'm not a dermatologist, and I'm certainly not a vulval dermatologist, but I would look for skin appearances that I think are suspicious and then refer them to my vulval dermatologist on our multidisciplinary team. Next. Now, some of the questions, what would look easy to begin with, were actually the most difficult. One example was, what's the best treatment for vulval pain? The answer is I don't know. Because each of my patients are different. Each patient has their own triggers. Each patient has their own beliefs. Each patient has their own comorbidities, and the list goes on. So I don't think there is one size that fits all. However, if you look on the left-hand side of the slide, you will see the obvious reduction of triggers and things that irritate the vulva. And most of them, I'm sure, are obvious to most of you because you will have, by elimination, discarded it. Right at the bottom, I've put topical lidocaine. Lidocaine is a local anesthetic. It comes as a gel, which is water-soluble, or it comes as a ointment, which is thick and oily and therefore stays on quickly. If you're lucky enough for the lidocaine not to cause any burning when you apply it to the tender area, then my first choice of treatment would be lidocaine ointment. There's just a word of caution. If you're unlucky to have eczema or dermatitis, then you've really got to be careful about making that area worse. So I would say try it, give it a go, and just make sure you don't give yourself another problem of vulval pain caused by skin problems as a result of topical application. And off that list, you can see, don't use perfumes, don't use soaps, don't use detergents, don't use scented toilet paper. The list goes on. But once you've actually got a handle on that, you'll find that each of those contribute. And at the end of the day, it's an accumulation of different factors that will reduce the threshold for your pain getting under control. In the middle list, we've got TENS machine, your oral medication, like your codeines and tramadols, which actually don't do well for most people. And if you are controlled on opioids, that's codeine, tramadol, etc., my question to you is, does it satisfy the 5 A's? A, does it give you analgesia? That is, does it give you good pain relief? B, does it give you activity? Can you function better as a result of the pain being better controlled? C, does it improve your affect? Are you emotionally better as a result of the pain being under control? 4, is there aberrant behavior? There is a huge emphasis now on avoiding strong opioids for benign conditions because of the long-term effects of opioids, which include earlier risk of dementia, effects on fertility, and also cognitive functioning. And finally, are there any adverse side effects? Some of them are obvious, like constipation, in which case you need to improve your food intake, your diet, and drink plenty of water. The next list are the drugs, and you can see only a few of them are on. I've just put the common ones, the tricyclic antidepressants, the SNRIs, and the anticonvulsants. Now, if you're a young girl in your reproductive age, I would avoid using pregabalin or gabapentin, because if you get pregnant on these medications, the baby is at a risk of getting cleft palate. So you can see age also makes a big difference into choosing which therapy will work for which patient. Trigger point injections or massage are done by physiotherapists or by clinicians. Botox, very rarely. Remember, Botox is a toxin, and you've got to be careful where you inject these medications. If they are near a sphincter of the bladder or the bowel, you can get incontinence for a little while. And then you've got your nerve blocks and surgery. Now, before you think that, oh, surgery may be the answer to your problem, like in a vestibulodynia, which is sometimes used for focal vulvodynia, you have to remember you have to have all the other things in place, all the basics on the left-hand side of the screen. And the best results come in those patients who are psychologically stable. So that is one of the reasons why surgery is now becoming unpopular, because even though you may take the part that hurts, you've still got the remaining nerves attached to the spinal cord and attached to the brain. So paradoxically, you have a risk of getting phantom pain, where even though the area is excised, you can get even sometimes a worsening of your pain. This is why surgery is becoming less and less common, say, compared to the 1960s. When you consider nerve blocks, we use local anesthetic and steroids. And at the moment, with the COVID pandemic, we are unlikely to be injecting patients with steroids because steroids are transiently immunosuppressive, i.e., it reduces your immunity. So this is one of the reasons why all our clinical activity has been suspended during this pandemic. Fiona, my physiotherapy colleague, then deals with the list on the third side, on the right, looking at pelvic floor exercises, soft tissue massage, trigger point pressure, which is like a version of acupressure, biofeedback, and the use of vaginal trainers. Now, vaginal trainers are easily available on prescription, but there is really no point in giving a patient vaginal trainers if they don't have a suitable education on how they are to be used. And I think this is why Fiona gets very good results with her patients, because she puts a lot of emphasis on the individual needs for the use of vaginal trainers. And at the bottom too, although they take a very small prominence in terms of the whole picture, they're huge subjects. I'm currently doing my diploma in psychosexual medicine, and I've learned a lot about this subject. And I would encourage you, for those that feel that you need help, is to try and get local help. And the best ones are run by the Institute of Psychosexual Medicine, IPM, on the websites. And then finally, dealing with psychological factors. And I've gone so far as covering two areas, yoga and mindfulness. And I know this has been covered in previous webinars by different experts, but I feel so strongly about it. I've got a couple of slides that I want to share with you. Next. So if you think of any human experience, think of anything other than your vulval pain. First, you have your thoughts about that experience. Was it good? Was it bad? Did it really help? Or was it unhelpful? What are the feelings? Did it make you sad? Did it cause you worry? Did it make you angry? Did it make you fearful? Or was it good? And then the sensations and your perception of what that experience was. Did it cause pain? Did it cause itch? Was it something to do with sound, sight, or some other sensations like cold and heat, taste and smell? And I can imagine all of you will have had experiences in the past that you can relate some smells with, like a good perfume, with a pleasant, as a pleasant experience. But the most important one is memories. And when memories are unpleasant, you can imagine as you get older, it becomes more and more complex. And one of the reasons why I feel very strongly about women with vulval pain addressing all their factors, including psychosexual medicine, because there is a tendency to sort of forego these human rights, one might say, just in order to cope with their lives. And then finally, what are the urges, impulses, and movements? What does it goad you to doing more, or does it put you off doing something? So basically, vulval pain can be either a positive experience if it allows you to develop some other aspect of your career, maybe your professional career, or does it inhibit you and you withdraw from life itself? Next. And this is my last slide. I apologize for the noisy slide, but really psychology is just as important as medication, just as important as a nerve block or anything else. If you've got pain, you're more likely to be anxious, you're more likely to be fearful, worrying about the future, you're more likely to sleep badly, and all these contribute to that experience. We've already talked about the medical comorbidities, but also don't forget, just because you've got vulval pain doesn't mean that you're not prone to getting other psychiatric problems like depression, anxiety, panic attacks, or PTSD. And the tragedy is, medications very rarely answer these needs, and that is why it's important to go to the appropriate specialist for the appropriate conditions. Now here's a challenge. If you're in pain, your autonomic nervous system, that is the system you cannot control, goes haywire. So your blood pressure goes up, your heart rate goes up, you start sweating, you get palpitations, you want to empty your bladder, you feel fearful. Strategies like CBT, yoga, mindfulness calm down the autonomic nervous system and encourage a healthy and a holistic way of living. So basically, you're switching off your stress response, reducing the amount of cortisol that you're producing, and therefore your heart rate comes down, your blood pressure comes down, your breathing is less labored, and your blood glucose requirements go down. Yoga also improves your musculoskeletal system. It increases your muscle strength and increases flexibility, but pure yoga also looks at focused attention. That is your ability to calm your body down. And that's what mindfulness does. And it's been pioneered by John Kabat-Zinn in Boston, in the United States. And it is now the #1 treatment for chronic pain. All this stems from Buddhism. And Buddhism takes an emotionally detached observation. Live for today, don't worry about yesterday, and don't be fearful of tomorrow. Enjoy what you're doing now. And it can be something very simple. The fresh coffee that you have first thing in the morning, the thrill of brushing your teeth or combing your hair or having a massage or looking at a beautiful flower or a beautiful picture in a museum. And if you think this is all not scientific based, well, there is proof by neuroimaging. If you do MRI scans while people are resting and being defocused, guess what? All the pain pathways switch off and come down. And finally, the last strategy I want to talk about is ACT, Acceptance and Commitment Therapy, which teaches you to sort of accept that you've got vulval pain, because there's nothing you personally can do other than what we've talked previously, but actually use that as a means of developing yourself for future care. So I hope that has given you a quick summary of what I think as a clinician is the basis of vulval pain and its management. Thank you.
Brilliant. Thank you for that, Winston. I wonder, that's a lot of information to take in there, and I think that's been really useful. And it's answered quite a lot of the questions that have come in. Something that came in quite early on is how can someone get a referral to a pain clinic or to a multidisciplinary team?
I think now with the NHS so open, you can refer yourself to a specialist anyway, certainly in NHS England, by getting your GP to refer you on.
We've got a question here. Why is my vulval pain cyclical with my menstrual cycle?
Oh, that's an excellent question. The nervous system is linked with your endocrine system. So, like in the comorbidities, if you've got vulvodynia, for example, you're more likely to have thyroid dysfunction or hypothyroidism. Now, with your menstrual cycle, you've got a cyclical rotation of your hormonal production. And guess what? It affects the nerves and therefore affects the pain. So if you can take some strategy of reducing the fluxes of menstrual cycle, the binging, the swelling, the tender breast, etc., you will also reduce your pain. So that is just a part and parcel of the nervous system and the endocrine system working hand in hand.
Okay. So we've got questions on medications, and you mentioned a number of medications there: gabapentin, pregabalin, and the tricyclics, and a few others. Are there any best medications?
Well, funny enough, I think amitriptyline and pregabalin and gabapentin are the best around, because if you were a betting man and you had 100 women with vulval pain, these three are likely to be the most successful. There is a tendency to dismiss them because they're cheap, they're easily available, they've been going on for years. But the secret is not to use it in the doses for depression or for epilepsy. I go for low doses, washed in very slowly, and allow the patient to get the benefits. For example, with amitriptyline, you would expect over 8 weeks of being washed in with low dose amitriptyline to get better sleep, a better mood, and then by 8 weeks, better pain relief. So it takes a long time. And therefore, these drugs should be washed in slowly and washed out. The same applies to the anticonvulsants, the anti-epileptic drugs like pregabalin and gabapentin. But I tend not to use them in younger girls in case they get pregnant, for the reasons I described earlier. However, if a lady is menopausal and she's having menopausal flushes, I would use gabapentin because that helps flushes as well. So I think it just depends on the makeup of the patient, what their other problems are, on the basis of what I would choose. But I would reckon those 4 drugs are probably the ones that will give you the best results for the majority for most of the time.
Okay. Now, we know that many women experience side effects, and someone's asked, any tips for managing those side effects?
Well, I'm on amitriptyline and I've got my glass of orange next to me. I'd rather have a dry mouth and be in less pain than to have a wet mouth and be in misery and be in pain. So from a personal point of view, I think you've got to take the side effect profile of a drug, because any intervention has got a side effect. And don't forget costs as well. If you're going to pay for it privately, remember that's going to cost money. So all these factors need to be brought in before you make your final decision.
Yeah. Are there alternatives to amitriptyline? Someone's written here that it causes a terrible constipation, and then that in turn aggravates the vulvodynia.
Now that's, again, another good question, because we have one of the biggest lower bowel units in the country. So I get a lot of patients with constipation. One trick is to move from amitriptyline to its cousin, nortriptyline. But really, to the individual patient, I would say, rather than abandoning a drug, look at a similar drug in the same class. So if I put a patient on amitriptyline and they're getting constipation, I'd say give a trial of nortriptyline. It may reduce the side effects. And remember, side effects of a drug vary from patient to patient. So just because you don't get constipated on nortriptyline doesn't mean another person would. It's an individual trial and error.
How about someone who doesn't manage well with any of these medications that you've mentioned so far? Are there other forms of medication or therapies you might recommend? I know you've mentioned a few, but what comes to mind?
Well, I think the first thing to be sure of is, I want to go back to drinking alcohol for a second. You get, if you give 100 women alcohol, some will be drunk even before they've started drinking. And then you'll get the other extreme where they're still upright after several shots of vodka. The same applies to the reaction of drugs. You'll get people who are extremely sensitive and those people who are easily resistant. So those two extremes are very difficult. If you are sensitive, I still go for even smaller doses of drugs. So for example, on amitriptyline, I would try the liquid form. So I could even start at 2.5 milligrams as opposed to 10. So I do try and exclude all these possibilities before making recommendations. Now, herbs are becoming more and more common. I'm not an expert on herbal medicine, but I would keep an open mind. And I think this is where evidence-based comes into it. If you look at the evidence for herbal medicines, you need to go to places like India, China, Africa, where herbal medicine has been in place for thousands of years. And quite a number of drugs, and including analgesic drugs, will come from natural resources over time, because Mother Nature must have the secret somewhere in there. So yes, if you turn around and tell me that turmeric, extra turmeric helps your vulval pain, I'm happy, because at the end of the day, it's what helps you. So again, herbal medicine, you would have to do trial and error, but just be careful where you get the information from, and be very careful on the internet where the sources are, because some of the sources of these herbal medicines can be adulterated and can be toxic. So go to Holland & Barrett's, for example, rather than go over the internet where you think something's really exciting.
Okay, good advice. How about someone who is just getting flare-ups occasionally? What would you recommend for pain relief in those instances? The lady here has asked, is there anything other than codeine to use in those instances?
Okay. Now, patients with chronic pain, whatever that type is, will have background pain all the time and have flare-ups, which we call breakthrough pain. So for background pain, I'm talking about your amitriptylines, gabapentins, etc., or a combination. For breakthrough pain, it's actually very difficult, because we know painkillers actually don't make any difference. They may calm you down, they may sedate you, they may allow you to sleep. So what I tend to do is, say, for example, a patient has got vulval pain, and they, for most of the time, they are controlled by 20 milligrams of amitriptyline. And when they get a flare-up for a few days, I would say to them, go up to 30, get on top of it. When it stops, go back to your baseline. So that would be my first choice. And it's the flip side of that is, if you are on such a medication, like say amitriptyline, and you're doing reasonably well, and it's summer, you're feeling cocky, you want to come off your medication, please don't. because when you come off your medication, it takes about 6 to 8 weeks for the drugs to be completely washed out of your body. And if you have a relapse, it'll be another 6 to 8 weeks before you can get control again. And sometimes that control is difficult. So my advice is to keep on the lowest dose as a background. And if you start getting symptoms, increase your dose.
Okay, what's your advice when pain medication interferes with sexual function?
Now, that's a very difficult question, because all drugs that we use in terms like, for example, the tricyclic antidepressants, anticonvulsants, have an impact on your whole sexual being. For example, weight gain is one. Having a muggy head, being able to relax, being in the mood, having a partner that will understand. So I think it's a rather difficult question to answer. And I would say, if in discussion or in a decision made when you're not stressed out, try and work out how these drugs would impact on your sexual function. Does it reduce your libido? Does it just make you drier and less moist? So I would say take your individual links, discuss it with your GP, or if things are really complex, my recommendation is a good psychosexual counselor.
All right. Are there any support services which can help patients who need to safely taper off a high clinical dose of pregabalin?
I don't know of any, and I think that is one of my big areas of time occupied. Usually, if a patient's on high dose of pregabalin, I usually have to detoxify them if they want to get pregnant. So I would ideally like a girl to be free of all drugs for at least 3 months before getting pregnant. Now, if they're on a high dose of pregabalin, say the maximum dose is 600 or 300 twice a day, I would reduce it by 25 milligrams twice a day over 2 weeks. It's a very slow detox, but it just allows you to bring it down slowly. So if you get a flare-up, you can go up again and try again. So it's a very gradual, slow detoxification policy. But if you happen to have drug problems with other drugs as well, I'm talking about your opioids, morphines, etc., then I think the best support services are with the drug agencies, because they have the psychological, they have the medical, they have the detox profiles already lined up.
What do you mean by drug agencies?
These are detoxification centers, normally in the community,
right,
that help you detoxify.
Right. Okay. So if we move on to topical treatments, you mentioned lidocaine. Can a GP prescribe lidocaine?
Yes, every GP should be able to do that. Sometimes availability may be difficult. Talking about other topical agents, which is interesting, very few of my vulval pain patients get benefit from menthol, which is a very cooling. You can get them in different strengths, and they're easily available, and they don't help everyone, but they help some. Now, there is another interesting topical list of drugs. You can get amitriptyline, you can get gabapentin in a cream, but this needs to be compounded by a specialist pharmacy. And I'm still struggling 15 years in Manchester to get that. But now that we amalgamated with Manchester Royal Infirmary, who have a compounding pharmacy, we will be able to get patients with gabapentin creams and amitriptyline creams. So this is an exciting thing, because you're now applying the drug to the parts that need it without the systemic effects of affecting the whole body. But a word of warning, there are very, very few centers in the UK that have such facilities, and by definition are expensive.
Yeah. Will there be more do you think?
I think over
emerging?
time, I think topical applications for analgesia is becoming the trendy way
Okay.
of delivering drugs.
Okay. And there are a number of questions on that. How can I get compound creams when my doctor dismisses this? I think this is a hormonal problem and my pH level is off. And ureaplasma?
Yeah. You have to just be very careful, because this question refers to the pH of the vagina, which will alter as you get older, will alter if you've got coexisting infection. Ureaplasma is just another bacteria that can get involved in this. So what I'm saying is, if you feel your pain is hormonally mediated, then obviously altering the hormones like topical estrogen and occasionally even topical testosterone will help your condition. But for this, you need to go to an endocrine gynecologist. If it's infection, then you're more likely to have to go to a gynecologist with an interest in genital infections, because that again is a specialist area. And that's why when you ask what is the most effective treatment for vulval pain, the answer is I don't know, because it depends on what your cause is. So if yours is hormonal, the chances are that you'll need hormonal therapy. If yours is infective, you might need treatment with an antibiotic. If it's a muscular, then it needs physiotherapy. So it's a very rich, very complex interaction.
Of course, we know, don't we, that it's not necessarily going to be just one of those things.
No.
It may be a combination. Yeah. Is there an internal numbing gel I can use for vestibulodynia? I don't know whether this question is about lidocaine or something else. So.
I think lidocaine, certainly in the UK, lidocaine is the most common local anesthetic. Just be careful about numbing creams. The caution is this: is it lidocaine or is it some other local anesthetic, things like prilocaine or whatever? They can have side effects. They can sensitize the skin, and you have to remember the vulval and the vaginal area is very rich in blood supply. So if you apply something topically, it can be absorbed systemically. And the worst errors is, what are you trying to numb, and for what purpose? And it's a little bit of a hit and miss. I can see the logic if you've got a small area, like in focal vulvodynia, a pea-sized amount of a lidocaine ointment might help you, or to facilitate intercourse. But trying to use the amounts to numb a whole area may not be a good idea.
Okay. On to injections, nerve blocks. So you touched upon a little bit. So steroid injections, is that a beneficial treatment option? Are injections successful for pain relief? And then the lady has asked, if they are successful for pain relief, where and what tissue would you inject? How often?
Okay, so that's a very good question. I would go even though I do injections, I would go so far as saying injections are a very low priority. I always believe if you haven't got the basics, like avoiding the triggers, leading a healthy lifestyle, dealing with your psyche, no injection is going to work unless that is under control. So the blocks work best for those who've got a good foundation stone, got a good understanding of what the blocks are supposed to do. No blocks are curative. They're just attenuated for as long as the steroid lasts. You have to remember that there's a downside of chronic steroidal therapy: immunosuppression, making the skin more friable, adding to complications like worsening your diabetes. So these are the things that we need to be careful about. Where you put the steroid depends on what your target area is. If it's focal vulvodynia, a tiny area between 4 and 7 o'clock of the vulva, then injecting a steroid into that area will work. If it's a more global area, you might have to target the motorway rather than the B road and go for the pudendal nerve block. And that will really depend on the expertise of the pain physician who is looking after you.
Okay. And you mentioned that having that foundation stone is important. So would that mean that pudendal nerve blocks wouldn't really eliminate the pain completely unless that foundation stone is
I wouldn't say there's nothing I do that will take your pain away completely. So what we're talking about is an accumulation of 10% here, 15% here, and before you know it, you're above 50%, which I think in pain medicine is a very good result. If a patient is lucky to get 100%, of course I'll be excited. But I will also know the other extreme is when patients don't get any relief from anything. So you have to remember, like the alcohol bit, some are very lucky and some are not. The majority of you will be in the middle somewhere to get some pain relief, which is why I always say to the patients, aim for 30% because it is realistic.
Okay. What's the next step after trying nerve blocks and infusions and having no success?
Very difficult. I think the next step, and that's why I mentioned acceptance and commitment therapy, ACT, because at the end of the day, you can go through the whole gamut of treatments, and I, like all other pain consultants, have our failures. And my job is, if I have tried everything I can, and I know there's nobody else in the country that can help my patients, and there are plenty of that, because you have to remember, there comes a time when a few patients will go from one doctor to another and exhaust everything. And you have to understand from a patient perspective, they're willing to try anything just to get pain relief. But that implies you're psychologically driven, looking for that nirvana state, which is not likely to be obtained. So what we do for our patients is we try and support them, try and go back to square one, go back to the foundation stones. And finally, the main strategy, which we've now started doing earlier, is introducing the concept of motivational interviewing. You're 17 years old. What would you like to have achieved by the time you're 22? In terms of your personal life, your professional life, your financial life, your social life, your sexual life, and work out what you'd like to achieve in the ideal, and then work backwards. And that really focuses you on what is realistic and what is unrealistic. The biggest tragedy of vulval pain is patients think they're alone. And for us that work in this area, we know it's common, but nobody likes talking about it because we have to talk about being struggling to keep going. You're talking about pain that just intrudes every facet of your life, not having a healthy sexual life, and it just goes on and on. So it's always useful to review it with a piece of paper when you're in a state of calm, worked out. It doesn't matter what age you are. I do it every new year. Work out what do I want to achieve in the next year. Now, this year's plans were all messed up with the pandemic. So that's life. And I think it's just taking control of small bits, going to college for the first time maybe, or trying a hobby, achieving something which may be nothing to me, but maybe a Mount Everest to you. So let the patient decide their goals and alternatives to allow for distraction, so that as their life goes on, the vulval pain hasn't stopped progress in the other domains of their life.
Yeah, it's really important, that focus, isn't it, on personal valued based goals.
Yeah.
And those small steps. Yeah. Okay. We've got a question coming here about Oragel. Oragel? Don't know that?
No idea.
Okay.
Sorry.
All right. Okay. Sorry about that.
That's all right.
All right. I have a history of vestibulodynia and vaginismus. I'm due to have a vaginal birth, first child, in 2 months. I haven't experienced any vulval pain for a while, and none of my pregnancy. I'd like a home birth and accept that this comes with reduced pain management options. Do you have any advice to help prevent a flare-up of these conditions and associated pain during or after labour? I'm particularly concerned about a episiotomy. Is doxepin or naltrexone useful in treating itching in the vulva? I'm currently taking 1,100 grams of gabapentin, which is controlling pain.
Is that all one question? Is that all one question?
Yes, it's one question, which is controlling pain but not severe itching.
Okay.
You can chunk that.
I think I'll go for the exciting one, having a baby. The reason why the patient's pain is less is that the hormones of pregnancy are analgesics. Okay, so that's the reason why you're more comfortable, certainly in the second and third trimester. Delivery is always a big worry for patients with vulval pain, vulvodynia, because you think, oh my God, I'm going to pass a baby through this painful area. Now, we support our young mothers-to-be by looking at what is good for the mother and what is good for the baby. A birth by vagina is the best for the baby because as the baby is born, the baby gets inoculated with the mother's feces. And that fecal transplant gives the child's immunity for the rest of their life. So I'm a big fan of vaginal birth. Secondly, once the baby is born, breastfeeding produces oxytocin. And oxytocin is what is produced in orgasm as well, is the best analgesia in the world. And that is why in America, there are now studies for oxytocin sprays for analgesia. So I'm very keen on mothers have as much a natural birth and B, go on for breastfeeding because it's good for immunonutrition, it's good for the uterus contracting down and mothers recovering their figures, and it's also good for the baby. Now, in terms of drugs at pregnancies, I've got to be careful. I cannot answer the specifics because obviously itching is a cousin of pain, and itching is sometimes a sign of another problem like a skin problem down below or whatever. So I can't really answer that question because it's too specific for me to answer that.
Sure. Yeah, understood. Yeah, so there's a couple of questions that are the same about vaginal birth, which you've answered. Do you recommend anything to reduce vaginal pain and tightness during pregnancy?
No, I don't. I'm very much in trying to let Mother Nature run a pregnancy. I feel very hesitant in giving advice on what should really be a very pleasant experience. However, your midwife, your antenatal obstetrician are there to give you advice if there is something peculiar to your pregnancy that needs addressing, either by some coexisting medical problem or something that should be discussed right at the start of the journey. So most of my patients with vulval pain who intend getting pregnant, I warn them that this needs to be well processed right at the start of the journey. So you choose your analgesic approach. Are you going to take gas and air? Are you going to have a PCA? Are you going to have an epidural? So have these all planned up, just like a plan of action for war. Cover all options, so at least you have a game plan when the baby's due.
Okay. All right. Just a few more questions here. In terms of pain management strategies, questions about anti-inflammatory foods that can be tried, and dietary options?
Oh, I like that question, because it's becoming very important in pain medicine. The IASP, International Association of Study of Pain, have come out with a very interesting article, and I'll read it. Read the summary. It's 6 aspects. First of all, reduce your oxidant damage by having a lot of fruit and vegetables. 2, omega-3 fats and olive oil, which you can get in salmon and various seeds. Very good fish oil, very good with omega-3. Third, make sure your vitamins are well up to date, especially your vitamin D, which is important for muscle fatigue, the vitamin B12, which is for nerves, and magnesium minerals, because that reduces muscle spasm and nerve pain. 4, water intake. Drink at least 2 to 3 liters of clear water, preferably not with vodka and not with caffeine or tea. 5, increase your fiber and make sure that you've got probiotics so that your fecal microbiome is as healthy and thus reduce the risk of getting urinary tract infections. And finally, don't do those takeaways. Reduce your sugar intake, because those are not healthy. They just make you fat, put on weight, and are more prone to chronic disease. So that's a good question.
And a great answer. Brilliant. Okay. In terms of practical ways one can bring, what you learn about pain management into their lives, what can be done? So practical pain management tips.
You remember the last 2 slides, we talked about psychology and we talked about yoga and we talked about mindfulness. That is easily incorporated. I speak as somebody who struggled with pain management over the years. This is despite being a pain management specialist, because if you think about it, pain is personal. It's personal. My pain was nerve pain due to a stroke, and it was horrific. And I thought I was going to die. So I'm very glad that I'm still alive. So you have to take it in context of what that pain means to you. And my wife, who's a neonatal nurse, said to me, "You need to get a life." And I was rather off-put by that. After 35 years of marriage, I thought that was quite insulting. But actually, when I calmed down and actually thought about it, she was right. And so mindfulness has been a tremendous impact on my quality of life. And just from a personal thing, just to be able to share this, I was born a Catholic. I wanted to be a priest, and my mother said, "No, till you become a doctor." I then obviously got married and had a son, but now religion means a lot to me. So I think spirituality, religion, mindfulness, yoga, all these concepts you can, and also being nice to people. Just do something nice for somebody a day. It could be your neighbor, just doing a shopping for a friend, or just sending a card, or saying some nice things to your doctor when you next visit them. These are positive things that actually improve your own emotional health.
Yeah, I love that. A random act of kindness. Yeah.
Yes. Yeah.
Lovely.
And we're seeing that during the pandemic.
Yeah. Just a quick question on physio here. What's the best method to treat vulvodynia pain, which is caused by muscular tensions in the pelvic floor?
Do you remember when we talked about physiotherapy, I talked to you about the different kinds of physiotherapy. If you've got vulvodynia, please do not go to a women's health physiotherapy unless they understand that you have a hypertonic situation. Fiona, my physiotherapist, is not only a women's health physiotherapist, she's also a pelvic pain physiotherapist. So there is a big difference between the two. The women's health physiotherapist wants to tighten up your pelvis after childbirth or incontinence. But a pelvic pain physio is trying to treat you to relax it. So if you go to the wrong person, or to the, not the wrong person, but to the wrong specialist in physiotherapy, you could make things worse. And you have to look out for it on the internet. Or if you contact your local women's health physiotherapy, if you ask them, do you know anyone locally that does work for pelvic pain? It's a very small number. I know about a dozen spread over the UK, but I'm sure there are lots more that do it.
Okay. And then one final question here. If someone has had vulval discomfort almost all of their life, do you think they can overcome it? And we're not necessarily talking about 100% relief, but do you think that they could get better?
Yes, I do, because I think it depends on what your problem was in the first place. So if your problems were hormonal, as you reach the menopause, your hormones are going to change. So there may be a chance that might improve. It may improve because you have adopted a different lifestyle where you're concentrating, I don't know, maybe your career or your business, or you've become a famous watercolor painter. You've diverted your energies to other things, and therefore vulval pain itself occupies only a smaller part of the bigger pie. And that's the basis for distraction and yes, so I'm confident there are always possibilities of the vulval pain being less intrusive over time, because a lot of it is how you handle it or allow it to handle you.
Yeah. Okay. Brilliant. So we do have more questions, but we've got more experts coming up in the following weeks, which I'll talk about in a moment. Winston, any final words for those who are listening?
During this COVID pandemic, when you've got a little more time on your hands and you've cleaned your house 16 times, just reflect on what we've discussed today and start building up a roadmap of where you want to go over the next day, next week, next month, next year, next decade. And take control, never give up, and always think positive.
A lovely note to end on. Thank you so much, Dr. de Mello. Before I tell everyone who we've got coming up next week, I just want to say thank you for all the donations that have come in over the last few weeks. It means that we can have the software to run these, the security. We're also revamping our website. So these webinars will be available soon, together with more up-to-date information and resources on that revamped site. After this webinar, there will be a donations page that comes up. If you're watching, there'll be watching a replay, a link coming at the bottom of the screen. Any small donation, only if you can, is appreciated. It just helps us keep going and help you better too. So next week we have Selena Doggett-Jones, an integrative relationship and psychosexual therapist. So whether you're in a relationship or you want to explore ways to have pain-free sex, or even the possibility of enjoying sex again, the sign-up link will be emailed out tomorrow. I've seen the volume of questions on sex. It came in for you this week, Winston. They'll be coming in each week. So they will be answered next week by Selena, and we hope you'll be able to join us then. Thank you again, Winston, for joining us.
Thank you, Sharon, and thank you, Kay, and thank you for all the people who took part in the webinar. I wish you all the best for you, your family, and friends.
Wonderful. Thank you all for joining, and see you next time.
Bye-bye.